Hey everyone, welcome to this explainer. Today, we're getting incredibly granular. We are breaking down the exact decision tree for treating hyponatremia in the setting of SIADH, the syndrome of inappropriate antidiuretic hormone. My goal here is to cover every single point step by step so clearly and thoroughly that you absolutely won't need to crack open a textbook to master this concept. We are taking it one point at a time, so let's get into it.
Here is our roadmap for today. We'll start at the top with the SIADH decision tree, then move into the aggressive protocol, step down to the intermediate treatment protocol, look at the routine treatment protocol, and finally wrap up with managing refractory cases.
All right, part 1, the SIADH decision tree.
So, what is our fundamental starting point? It's a serum sodium level of 135 milliequivalents per liter or less. The second your patient hits 135 or drops below it, boom, you are officially inside this treatment algorithm. From that starting line, the pathway splits right down the middle based on severity. On one side, we've got mild to moderate hyponatremia. That is going to be your 125 to 135 range. On the flip side, we have severe hyponatremia, which is defined as any value tanking below 125. Let's trace that mild to moderate branch first. The absolute very next question you have to ask is, are there symptoms? If the patient is totally asymptomatic, they go straight to routine care. But if they answer yes to having even mild to moderate symptoms, we're talking anorexia, a headache, difficulty concentrating, irritability, dysgeusia, or just some muscle weakness, that changes the game completely. It means the brain is already struggling with the fluid shift. So those symptoms bump them right out of routine care and straight into the intermediate treatment protocol.
Okay, but what if the sodium is severe, under 125? Your very first question here shifts to duration. How long has this been going on? If we know for a fact it's been under 48 hours, you have no choice. That mandates the aggressive treatment protocol. But if it's been 48 hours or more, or if you honestly just don't know, you've got to look at the symptoms. Severe symptoms like coma, seizures, or delirium, that's the aggressive protocol. Moderate or nonspecific symptoms, maybe just a headache or some lethargy, that's your intermediate protocol. And surprisingly, if they have severe hyponatremia but literally zero symptoms, they get routed to the routine protocol.
So when you map this all out step by step, it creates an incredibly clean decision tree. Every single patient condition routes perfectly into one of 3 distinct protocols, driven entirely by severity, duration, and symptoms. Which brings us to part 2, the aggressive protocol. Now you're only going to trigger this intense protocol under strict emergency conditions. The sodium has to be severely low, under 125, and you need one of 2 things to be true. Either the onset was incredibly rapid, happening in under 48 hours, or the patient is actively exhibiting dire symptoms, think coma, seizures, or delirium. Since this is an absolute emergency, your actions need to be fast and decisive. Step 1, get them to the ICU immediately. Step 2, start a 3% hypertonic saline infusion. Your standard rate is going to be 1 to 2 milliliters per kilogram per hour. But if the patient is having seizures or is in a coma, you actually double that rate to 2 to 4 milliliters for a limited time. And step 3, hit them with 20 milligrams of IV furosemide or Lasix daily. That diuretic prevents volume overload and boosts atrial natriuretic factor, which essentially acts as a chemical signal forcing the kidneys to dump the extra sodium you're pumping in. Now listen closely because this is where the strict speed limits come into play. You have to check that serum sodium every 2 to 3 hours. Your hourly goal is to raise it by just 1 to 2 milliequivalents, but here's the hard, non-negotiable rule. You can absolutely never exceed an 8 to 10 milliequivalent total increase in 24 hours, or 18 to 25 in 48 hours. And if the duration was chronic or unknown, aim for the lower end of that limit just to be incredibly safe. Oh, and don't forget to track the potassium lost in the urine and replace it.
So why are we so obsessed with these speed limits? Because pushing sodium too fast can trigger osmotic demyelination, also known as central pontine myelinolysis. It is devastating. You'll often see it signaled early by lethargy and affective changes, meaning sudden shifts in mood or behavior, usually right after you thought the patient was improving. If you spot these signs, stop the treatment immediately. You actually need to modestly re-lower the serum sodium using something like DDAVP to reverse the damage.
All right, let's shift gears to part 3, the intermediate treatment protocol.
You're going to use this protocol for 2 main patient groups. First, symptomatic patients whose sodium isn't severe, hovering between 125 and 135. Second, patients with severe hyponatremia under 125, where the duration is chronic or unknown and their symptoms are just moderate or nonspecific, like a nagging headache or lethargy.
Because it's not a full-blown emergency, we step down our interventions. Instead of the harsh 3% hypertonic saline, you're going to run a standard 0.9% normal saline infusion. Keep that IV furosemide at 20 milligrams a day to control volume, and for step 3, keep a drug called conivaptan in your back pocket. It's your backup plan to consider if the case becomes refractory and resist this initial treatment.
With the intermediate protocol, you can stretch out your monitoring intervals just a bit, checking sodium every 4 hours instead of every 2 to 3. Your hourly goal drops to a modest 0.5 to 2 milliequivalents per hour. But look at this. Those hard safety limits for 24 and 48 hours, they stay exactly the same. You still max out at an 8 to 10 milliequivalent increase in 24 hours and 18 to 25 in 48 hours. The threat of osmotic demyelination is very real, even if the initial symptoms were milder.
Next up is Part 4, the routine treatment protocol. This pathway is strictly reserved for your entirely asymptomatic patients. We're talking about someone with a mild to moderate drop between 125 and 135, or, believe it or not, even severe cases under 125 if the duration has been prolonged over 48 hours and they are showing absolutely zero symptoms.
The approach here is refreshingly conservative, no IV infusions at all. The main intervention is strict fluid restriction. To give you an idea, in pediatrics, that looks like 1 liter per square meter per day. While you restrict fluids, you want to actively encourage the patient to eat more dietary salt and protein. But pay close attention to this massive red flag. Avoid fluid restriction like the plague if the patient's hyponatremia is happening right after a subarachnoid hemorrhage. You have to be extremely careful there.
Finally, let's cover Part 5, managing refractory cases.
So what happens when the primary protocols fail and the sodium refuses to budge? First, you can try an oral option, demaclocycline. It's actually a tetracycline antibiotic, usually given at 300 to 600 milligrams orally, twice a day. It works by cleverly partially antagonizing ADH right on the renal tubules. But a quick warning, its clinical effects are pretty unpredictable from patient to patient, and there's a real risk of nephrotoxicity. Keep a close eye on those kidneys.
Alternatively, there's conivaptan, also sold as Vaprisol. This is an IV non-peptide antagonist of V1A and V2 vasopressin receptors, and it is FDA approved specifically for hospitalized euvolemic or hypervolemic patients with moderate to severe hyponatremia. The standard dosing is a 20 mg IV loading dose over 30 minutes, followed by a 20 mg continuous infusion over 24 hours. If the sodium still won't move, you can push that to 40 mg. But listen up, the absolute max duration is 4 days. You cannot exceed that, and you've got to watch carefully for drug interactions.
Now, you might see some older textbooks casually mention lithium for this condition, but let me be perfectly clear. Based on current protocols, lithium is just not very effective, the side effects are completely unacceptable, and it is outright not recommended for treating SIADH. Just take it off your list entirely.
So, as we wrap up this incredibly detailed, point-by-point look at the SIADH treatment algorithm, it leaves us with a fascinating question. With highly targeted drugs like conivaptan evolving so rapidly, are we eventually going to see the dangerous tightrope walk of 3% hypertonic saline become a thing of the past? It's definitely something to think about. Thanks for joining me for this explainer. I hope this granular breakdown cleared up every single point, so you've got the entire protocol completely locked in.